Thank you for joining us today. I am honored to host a session today for aplastic anemia and transplant. And also, I'm honored to have Dr. Richard Child, Scientific Director of NHLBI, joining us today for case-based learning session on aplastic anemia and transplant. There has been several exciting developments for transplant options for aplastic anemia patients. So through our complex clinical scenario today, we will delve into critical diagnostic and treatment decisions, aiming to enhance our collective approach to managing these challenging diseases. So again, thank you, Dr. Childs, joining us.
Thank you. Great to be here. Okay, so I have no disclosures, first of all. So the case this morning is a 38-year-old female who presents with a 3-month history of progressive fatigue, easy bruising, and recurrent oral aphthous ulcers. Over the past month, there have been reports of increased shortness of breath with exertion and several episodes of epistaxis. Her past medical history is unremarkable, and she takes no regular medications. There's no family history of hematologic disorders or early cancers. Her CBC shows a low white count and a low ANC with a neutrophil count of 300, a hemoglobin that's low at 6.8, and a platelet count that's low at 8,000. Reticulocyte count is 0.1%, extremely low, and the absolute lymphocyte count is 800. Bone marrow biopsy shown to the right shows severely hypocellular marrow, estimated cellularity less than 10%, with prominent fat spaces and scant hematopoietic cells. Cytogenetics were normal, female 46XX. Flow cytometry on peripheral blood was negative for a PNH clone. Additional specialized testing for inherited bone marrow failure syndromes, including chromosome breakage analysis for Fanconi anemia, telomere length assessment are pending due to the patient's age and lack of family history. Given the severe pancytopenia and hypocellular bone marrow, a diagnosis of severe aplastic anemia is suspected. Just to comment on the lab findings and the history, the fatigue, dyspnea, and exertion presumably is from the anemia, and the bruising is presumably from the thrombocytopenia. At this point, the patient's severely neutropenic, but we're not getting a history of any opportunistic infections at this point. And the bone marrow this is a pretty typical aplastic anemia bone marrow. In most cases, all you see are fat replacement. Sometimes there'll be the only thing that will be present is plasma cells, and that is just something to keep in mind because I have seen patients with aplastic anemia where there was a question about could they have myeloma because their bone marrow only showed plasma cells, but that was because the only thing that was really left was plasma cells, and the plasma cells actually weren't increased. The patient's hematologist initiated immediate workup for a potential stem cell transplant given the diagnosis of severe aplastic anemia. Her only sibling, a 42-year-old brother, was identified as an HLA-matched related donor, which is lucky because the chances of that sibling being a match is 25% just based on Mendelian genetics. Due to the rapid decline and severe cytopenias, the team is considering upfront transplantation. While awaiting final confirmatory tests and donor readiness, the patient developed severe E. coli bacteremia, requiring broad-spectrum antibiotics and multiple blood product transfusions. She successfully recovered, but her counts remained very low. Discussion began regarding the optimal conditioning regimen and graft source. Her brother, a busy professional, prefers to donate peripheral blood stem cells due to a quicker recovery time, but the team is weighing the risks. The patient successfully underwent a matched-related hematopoietic stem cell transplant, presumably using PBSCs. Post-transplant, her count slowly began to recover. At day 60, her neutrophil count was 800 and platelets were 25,000, but not yet fully stable. Chimerism analysis at this time showed 95% donor T cells and 80% donor CD3 cells. Clinically, there have been no signs of acute GVHD. So I just want to make a couple comments before we go through the questions on this patient. One, patient's lucky that with a single sibling, they had a match-related donor. And that it's important to make sure that when you meet with the family, that you understand who's in the family. I can't tell you how many times we have worked patients up, typed a donor that wasn't a match, and then started pursuing match-unrelated donors or haplodonors or cord, and then suddenly in the middle of the workup, we hear about the long-lost relative that nobody's talked to for 5 years, and suddenly there was a phone call the night before, and they would be more than happy to get typed, and they end up being, HLA identical. So very important to find out what the family dynamics are when you're looking at who the family members are. Second thing is that the patient had severe neutropenia on diagnosis and is certainly at risk for opportunistic infections, including bacterial infections. Before we had good antifungal therapies, fungal infections were really the thing that got these patients into trouble. The bacteremias obviously can be life-threatening. The fungal infections can be life-threatening and devastating, and important to think about, are you going to put the patient on prophylaxis? And this would be a patient that, in terms of bacterial prophylaxis, we really don't have any data that shows that bacterial prophylaxis is helpful. There's always concerns about altering the microbiome, and then that could lead to deleterious effects long-term, including could make the transplant outcomes even worse. But these patients certainly need to be informed. They're neutropenic, and they need to know that if they develop a fever, they need to get to the hospital within an hour to be treated as a febrile neutropenic. The second paragraph, just about the donor prefers to donate peripheral blood stem cells. I think that it's also very important that we all have different preferences, but as we'll discuss in a little bit, the outcome with bone marrow is clearly superior to peripheral blood stem cells. And the motivating factor for why a donor would want to donate PBSCs versus bone marrow needs to be clearly dissected, because the risks of bone marrow harvest for a donor are exceedingly low. It usually involves an overnight hospitalization, and the recovery is extremely quick after a bone marrow harvest. So all donors have preferences, but it's important that they be educated in the context, particularly when transplant outcome can be worse based on what their decision is and what their preference is. I want to also comment about the chimerism analysis that showed 95% donor T cells and 80% donor myeloid cells. That is not a typical engraftment profile that we see post-transplant. Usually with an aplastic patient, if their bone marrow is empty, they don't have myeloid cells to come back. So typically what we'll see in the myeloid fraction, the CD33 positive cells, is they tend to be all donor in a patient that has been transplanted. Even if the transplant is not engrafting very well, they usually don't have any myeloid recovery. So we typically will see, regardless of the transplant state, those donor CD3 cells being 100% donor, and then we lock onto the T cells to try to figure out what the status of the graft is. And if that T cell chimerism is low, below 50% donor, those are the patients that we get a little more concerned about in terms of long-term engraftment, because if you have more recipient T cells than donor T cells, that's a situation where the risk of subsequent graft rejection is higher. And when we have more donor T cells than recipient, here in this case, 95%, that usually tells us we have a pretty solid engraftment, and we're unlikely to lose a transplant. But we're going to go through some specific questions that are addressing this.
Thank you for going over the case. So I think, as you pointed out, it's really important to make the distinction between the inherited ones versus the acquired ones. So what are the diagnostic tests that you would recommend to do ahead of the time before starting on any treatment discussions?
Yeah. So this is a key question. Obviously, this patient upfront got a bone marrow karyotype. That's very, very important because we want to make sure the patient doesn't have some other disorder, including myelodysplastic syndrome. Patient also had testing for PNH, and PNH can often present with bone marrow failure. So for inherited bone marrow failure syndromes, really important that the patient undergo DNA breakage testing to rule out Fanconi anemia. And there's a couple of reasons for that. One is that if we're going to use a relative, and there's a potential inherited bone marrow failure syndrome, we need to make sure that there's not inherited bone marrow failure running in the family. So if we identify a patient has Fanconi or has a telomeropathy, that's going to make the related donors suspect. And we're going to want to look at them very carefully. We may want to do specific testing for bone marrow failure associated genetic disorders in those donors before we use them. One thing I wanted to comment about the Fanconi testing is this case is presented in the sense of urgency, that the patient's neutropenic, they have an opportunistic infection. I would never do a transplant on a patient without getting Fanconi testing. We have seen patients that surprised us and came back with a FANK gene mutation without a classic Fanconi phenotype that had DNA breakage testing that was abnormal. And one of the reasons that it's really critical with Fanconi in particular to not miss that diagnosis is that it significantly alters the way that we treat these patients, particularly with the conditioning regimen. If we use the traditional conditioning agents that we use to get these grafts in a patient without Fanconi, it would be lethal. They have severe cardiac toxicity. They have severe epithelial damage and mucositis, and really critical. You never miss a diagnosis of Fanconi in the context of bone marrow failure. So, I've had from fellows tell me, well, we need to go quick. Should we wait for the Fanconi testing? Trust me, by the time you go through the workup and the HLA typing and the planning and whatever, the Fanconi testing should be back. It's usually back in a week. Longest I've ever seen, was 2.5, 3 weeks, but there should be plenty of time. Other testing that we do for inherited bone marrow failure syndromes commonly is telomere length testing. We do that typically using a flow-based panel. It's very common to see in these patients short telomeres in the myeloid fraction. We focus in on the lymphocyte fraction. So if I see short telomeres in myeloid, but I see that the lymphoid telomeres are in the normal range, then that is not consistent with the telomeropathy. Sometimes if it's borderline and it's confusing, then we will say we're not sure if they have a telomeropathy. We'll look for phenotypic signs. If we don't see those, we will wait for the next-gen sequencing to come back, where we'll do a 50 gene panel for inherited bone marrow failure. Those gene panels take a while to come back. They're usually about 4 weeks to come back. I have done many, many, many transplants without having the next-gen sequencing panel come back, where I have normal telomere length and I have normal DNA breakage testing. So we don't always wait for next-gen sequencing. We often don't even do it in every patient where we don't suspect inherited bone marrow failure syndrome. So those are the key tests that I would pursue first, since I'm using an HLA-matched sibling donor.
Okay, so I think this is also a very important question. What is the urgency for transplant? I mean, you can break into the severe versus very severe patients, and what is our timeline to transplant each high risk or severe or very severe patients?
Sure. So, we break these patients up into different categories based on the degree of neutropenia. When we start seeing neutrophil counts below 200, we categorize them as being, very severe. that really is sort of framing the risk of opportunistic infection in those patients. So a neutrophil count below 500 is where patients are clearly at risk for opportunistic bacterial and fungal infections. But when their neutrophils start getting lower and lower, less than 200, sometimes we'll see patients that have ANCs of 0. These are patients that are at high risk for infection. Very important that these patients be placed on prophylactic antifungal therapy. We now have very excellently tolerated broad spectrum antifungal agents. Our personal preference is to use oral posaconazole because it covers Aspergillus as well as Mucor species and Candida. But it is something that I would say it just almost has to be a reflex when you see those levels of neutropenia. What's the urgency? Well, there is data that if you look at the interval from the time of diagnosis of aplastic anemia to transplant, that outcome is inversely correlated with that time interval. So patients who get a transplant quicker do better than patients that have a delay to go to transplant. So why would that be? Well, the longer you wait, the higher the risk of opportunistic infection. Also, these patients are getting transfused more as you're waiting. Each transfusion is an opportunity to become sensitized to alloantigen. And we know clearly that patients that are heavily transfused pre-transplant are at higher risk for poor transplant outcome compared to patients that have minimal or even no transfusion burden. There's also risks that are associated with being thrombocytopenic and bleeding risks. And in some cases, we will have patients even early on after diagnosis that are relatively refractory to platelet transfusions. Not uncommon to see patients coming in with platelet counts in the 5 range. They get a platelet transfusion, and then the post-platelet transfusion count is less than 10 still. These are patients that have risk for bleeding. The bleeding that we dread, that is unfortunately often fatal, is intracranial bleeding. So the longer you wait, the longer the risk that thrombocytopenia is going to translate into something riskier, catastrophic from a bleeding standpoint. Iron overload has also been shown to worsen prognosis, and we know that patients that have higher ferritins at the time of transplant have worse outcomes to patients that have lower ferritins. So the preference is to take patients into transplant with the lowest transfusion burden possible, both from iron overload and then from sensitization to alloantigen. So that is really what our sense of urgency is. And I can tell you that the ANC is a big dictator on that urgency. If we have a patient with an ANC that's 750, 1,000, that is anemic and thrombocytopenic, the urgency will be a little less than somebody that comes in with severe or super severe aplastic anemia.
Okay, great. So, I think we know HLA matched sibling favorable outcomes, but can you go over why is it strongly preferred, just to establish the base of HLA matched sibling donor?
Sure. So I think just to frame, what are the options for a patient like this? Basically, 2 options. One is a transplant. The second is immunosuppressive therapy with horse ATG, cyclosporin, and L-trombopag. That triple combination of immunosuppression and growth factor, TPO mimetic, has response rates in the range of 80 to 85%, and has an extremely low risk of morbidity. But patients that respond to immunosuppression have about a 25% risk of either relapsing or going on to clonal evolution, which could lead to myelodysplastic syndrome or to leukemia. So when making that decision about do you use immunosuppression versus transplant, a couple of things go into that. One of the most important is the age of the patient. We know that patients that are over the age of 40 have a higher risk of transplant complications than patients that are under the age of 40. Also, whether the patient has an HLA matched sibling or a matched unrelated donor is also a very important determinant. What are the advantages of a bone marrow transplant? The advantages are that if you're younger and if you engraft, that we don't have to worry about clonal evolution and MDS and leukemia, as well as relapse occurring. Although having said that, there are some patients that get transplanted that have very poor engraftment and occasionally will have secondary failure. So when we have an HLA available sibling in a patient that's under 40, the data would suggest that upfront transplantation, that the results are superior to immunosuppressive therapy. But I have to say, being at the NIH and working in an environment where we're a large referral center and where where Dr. Young and Dunbar and colleagues have pioneered novel immunosuppressive regimens, that upfront treatment with immunosuppression is certainly an acceptable alternative to bone marrow transplantation, given the fact that you don't have to worry about some complications that can occur with transplantation, including acute and chronic GVHD, which are chronic diseases, as well as the risk of secondary malignancy. And we know that about 5 to 10% of patients with a bone marrow transplant will develop secondary malignancy, within a 15 to 20-year range. So we also look at the performance status of the patient very carefully. If the patient has a poor performance status, let's say that they have medical comorbidity related to some other chronic disease, pulmonary fibrosis, or some cardiac disease, those are all things that are considered. Does the patient have an adequate performance status to be able to survive the transplant, the conditioning, and the risks of opportunistic infection, acute or chronic GVHD that may occur. This patient sounds like they're healthy. They don't have other medical comorbidity. So in this context, going immediately to a transplant with an HLA matched sibling, most people would consider that the standard of care with results that would be superior in terms of less relapse and clonal evolution compared to immunosuppression.
So I think this question also comes because of the some data are being reported, especially haplo regimens. If the match related donor is not available, what alternatives should be considered, and how do their outcomes differs from the triple therapies?
Yeah. So this is also sort of a age related question. We know that the outcomes for match unrelated donor transplants have been improving over the last 30 years as we've gotten smarter about HLA typing. We now typically will match for 12 antigens, 2 each in the A locus, B locus, C locus, DR and DQ loci. So we look through in the registry if we don't have a matched sibling donor for a matched unrelated donor. The chances of finding a matched unrelated donor really depend on the patient's race. For instance, in the worldwide registry with about 25 million donors, the chance of finding a perfect match with a Caucasian is in the range of about 60%. For other populations, African Americans, Asians, the chance of finding a match unrelated donor is going to be lower. And in some cases, we'll find mismatches that may be associated with a single mismatch, something we call permissive mismatch that may be associated with no worse outcome compared to a perfectly matched transplant. But any mismatch, in an ABCDR locus is going to be associated with worse transplant outcome, higher risk of graft versus host disease. So we prefer, if we're going to go to a MUD, to use a MUD that is a perfect match. We also like to use MUD donors that are younger. There's data that outcome with MUD donors that are under the age of 30 are associated with better transplant outcome, a lower risk of GVHD, probably just a reflection of a more naive T cell repertoire in younger patients and greater tolerance to alloantigen, accounting for less graft versus host disease. The other thing with MUDs to consider is they don't happen overnight. So when you find a match unrelated donor, there's all kinds of different scenarios. You could have a patient with a very common HLA type where there could be, hundreds of potential match unrelated donors. Some of those donors may have already undergone typing, high resolution typing, where we know exactly, whether that person is going to be a perfect match or not. And we may say, oh, we found 5 people that underwent high res typing and have a perfect match. And then that's where you start to say, okay, who do you prefer? And we'll start to look for a younger donor in the registry. The National Marrow Donor Program will then start to reach out to those donors and say, hey, are you interested? It's amazing how many people, when you call them, are suddenly no longer interested in donating. And, as you see, sometimes there are donor drives to get people HLA typed. I think sometimes these things are happening in places where people are maybe feeling peer pressure and they sign up with their friends, but they really have, no intent or chicken out when the time comes to donate. So it is discouraging when you do a search and you have a different scenario where you have 1 or 2 potential donors and you get excited, and then you find out that, one donor, when they're contacted, just got diagnosed with lupus, is very sick and they're not eligible. And then the second donor says, well, I have to think about it. I'll get back to you. And then they say, they don't answer the phone anymore. They're not available. Or in some cases, they'll say, well, I have a big meeting that's coming up next month and I can't do anything until, 2 months from now. And that's why it's not uncommon with match unrelated donor transplants to take 2, 3, 4 months to get those donors. And in that context, when a match unrelated donor is not readily available, that's a scenario where you may want to think, should I give this person immunosuppressive therapy and at least have a chance that within the next 6 weeks their counts would recover, and with severe neutropenia they would be out of that risk, as opposed to waiting for a donor for 3 or 4 months and running into big problems. Haplotransplants initially were reserved for patients that had failed immunosuppressive therapy. The Hopkins group now has moved to an upfront haplo transplant approach for all aplastics and have reported very favorable data, although it's not been compared to match unrelated donors. The caveat that I would say with an upfront haplo is that the conditioning that you have to use, the regimen that they use, has 400 centigrade of total body irradiation. So that's something to consider, because many of these patients are younger and the mutagenic effects of 400 centigrade radiation should not be underappreciated. So I think that it's still going to be to be determined what the role of a upfront haplo would be. The standard for most people right now would be if they have a MUD and that MUD's readily available. And if they're younger, particularly, we say under 40, but if they're really young, sort of adolescent or younger, the results with MUDs are approaching the results with matched sibling donors. So if that match unrelated donor is readily available, and it doesn't look like there's going to be a delay. That would be usually what folks would go to up front. And if there isn't a MUD donor, most folks would try a round of immunosuppressive therapy first. And if the patient responds, great. If they don't, that usually is felt to justify the risks that are associated with transplants that would have higher risks, such as a haplotransplant, where still, 10 to 15% of patients could reject the transplant. And some patients could develop acute or chronic GVHD or have an opportunistic infection. And then I just list the third option that we're exploring in the NIH, which is expanded cord blood transplant. I was telling Taha that we have a regimen that with expanded cord transplant has exceptional results in patients that have failed immunosuppressive therapy. And that may be something that someday, actually quite soon, that we may bring to the upfront treatment arena for patients that don't have matched sibling donors, because we've seen 0 chronic GVHD and we have a 95% engraftment GVHD-free survival with that regimen. So something to stay tuned to that may be coming soon.
Okay, great. So can we also a little bit go over the conditioning regimen for, especially maybe for related donors, and then can you also allude on the graft sources?
Sure. So a traditional bone marrow transplant, and bone marrow is the traditional graft source, would utilize cyclophosphamide and horse ATG. The side dose is 50 mg per kilo, 4 doses, so total 200 mg per kilo. And then horse ATG for 3 to 4 days. We prefer now, and there are other regimens that are out there depending on the risk. So if patients are HLA alloimmunized, and that happens sometimes early on, there are regimens that add fludarabine to the conditioning regimen. We utilize fludarabine in a lower dose of cyclophosphamide, 60 mg per kilo for 2 days, with horse ATG. But the standard regimen would be a Cy ATG regimen for a matched related donor. When it comes to bone marrow versus peripheral blood, the advantage of peripheral blood is more rapid engraftment, lower rejection, but a significantly higher risk of chronic GVHD and acute GVHD. And that translates into a reduction in quality of life, having chronic GVHD. So the data is pretty clear that for an upfront transplant with an aplastic, that bone marrow is the preferred source because of a lower risk of GVHD, in particular chronic GVHD. And this gets back to this case where the sibling preferred to donate peripheral blood stem cells. I can tell you right now, if I was sitting down with that sibling, I would say that that's not a good decision for his sister, because with an unmanipulated peripheral blood stem cell transplant with conventional calcineurin inhibitor and methotrexate GVHD prophylaxis, cyclosporin or methotrexate or tacrolimus, there's a 50 to 60% risk of chronic GVHD, compared to a bone marrow that has a risk in the range of about 20 to 25%. So for those reasons, we strongly recommend bone marrow for upfront transplantation. The one exception would be that if there was something that was being done to prevent chronic GVHD or acute GVHD, the folks in London will add Campath to the conditioning regimen and use peripheral blood stem cells. And that's a great drug for in vivo T depleting the graft, and is associated with very low incidence of chronic GVHD. So a Campath-based strategy with peripheral blood is acceptable. At the NIH, we'll use peripheral blood where we CD34 select the peripheral blood and T deplete it. And then we will add back a very small number of T cells to the peripheral blood at a dose that would be equivalent to what you would get with the bone marrow. A peripheral blood transplant has about 20 times higher T cells than a bone marrow, So the idea with that regimen is with CD34 selected mobilized PBSCs, you get a very, very high stem cell number, usually 2 or 3 times higher than a bone marrow, which may facilitate engraftment. But by putting that lower number of T cells in, the risk of chronic GVHD ends up being about what you would get with the bone marrow, if not a little bit lower. So these are, things that are still sort of investigational, but that's what the options are for patients. But the answer on the boards is bone marrow is preferred over peripheral blood.
Okay. And then I think it's important to talk about the GVHD prophylaxis for MRDs. And what is your preferred agent for haploidentical when it comes to prophylactic measures?
So for MRD, the standard of care, and this would be in the context of a standard transplant, not using any kind of in vivo T cell depletion, would be to use cyclosporin methotrexate as GVHD prophylaxis, or tacrolimus methotrexate. There is some data you can switch from a calcineurin inhibitor methotrexate to a calcineurin inhibitor with mycophenolic acid. In our experience, the risk of GVHD is higher with these mycophenolic acid calcineurin inhibitor regimens compared to methotrexate. So the standard would be cyclosporin methotrexate for an HLA identical sibling. If Campath is incorporated into the regimen, that's a whole different ball of wax. And those patients are at much lower risk of GVHD, and they may be managed with just a calcineurin inhibitor alone, for instance, for a brief period of time. Some regimens even incorporated with in vivo T cell depletion, sirolimus, into the regimen as well. And those can be, protocol specific. For haploidentical transplantation, in which there's no ex vivo T cell depletion, which is the majority of transplants, the standard GVHD prophylaxis would be cyclophosphamide post-transplant given on days 3 and 4 at 50 milligrams per kilogram per day for 2 doses, followed by a calcineurin inhibitor, tacrolimus, or cyclosporin, and often a brief course of mycophenolic acid for 30 days.
I think you went a little bit on this, but what chimerism analysis preferred?
Yeah, so I think, we usually look at myeloid T cell chimerism. The expectation is that myeloid should be mostly donor and T cell. That's what we don't know what it's going to look like. And I've seen bone marrow transplants with very low degrees of donor T cell chimerism, where it's in the range of, 5-10%. That's important information because let's say that a patient has nephrotoxicity from cyclosporin, and you're running levels in the 12 range, and their creatinine comes back at 1 or 1.2, and you have the great idea that I'm going to lower their cyclosporin goal from 12 to 5. That's a situation where you might not do that because those patients are at higher risk for graft rejection, and they're the ones that we're going to want to run higher cyclosporin levels, particularly early on. In contrast, if you have a patient with high degrees of donor T cell chimerism, they're not going to reject the transplant, and lowering the cyclosporin would not increase the risk of rejection in that setting. But those are also patients that are at high risk for GVHD. And there is data that higher degrees of early donor T cell chimerism, specifically 95% or higher in the first 30 days, identifies a subset of patients that are at higher risk of acute and chronic GVHD. And those are also patients that we're going to want to keep their cyclosporin levels or their tacrolimus levels in the high therapeutic range.
Okay. So, what will be the next step if it's poor graft function or failure post-transplant?
Yep. So we basically have 3 options. One option is, well, first of all, is identify why they have poor graft failure. And this can be multifactorial. Sometimes patients will get infections and their counts will go down. That tends to be transient. CMV reactivation, with neutropenia, for instance. That's usually you treat the CMV and the counts will come back. We look at medications. These patients are on multiple medications. Sometimes they're on drugs that can have immunosuppressive effects. Mycophenolic acid, if the levels are too high, can cause neutropenia. Bactrim sometimes can cause neutropenia. We've even seen patients getting, relatively common drugs that we think of as being innocuous that can cause thrombocytopenia and things like that, Pepsid. So, look for the cause. If another common cause is rejection. So, should you be increasing the immunosuppression in that patient because they have some recipient T cells that are suppressing the marrow? If we think that rejection is going on, we might increase the level of the calcineurin inhibitors. We might add a second agent. Sometimes if we suspect rejection, we see T cell chimerism falling and counts falling, we'll add sirolimus on top of cyclosporin or tacrolimus and maybe a short course of steroids. The other, potential cause is that there's just graft failure occurring in the context of some alloreactivity. So common to see patients with chronic GVHD having poor blood counts, thrombocytopenia, the most common, manifestation hematologically of chronic GVHD. So making sure the patient doesn't have chronic GVHD, and if they do, treating the chronic GVHD, so if they have skin manifestations or liver, it's often common to see hematopoietic involvement and to see that improve with treatment. If there's no clear etiology and you do a bone marrow and there's hypocellularity, and it may just look like poor graft function for unclear reasons, we do have the option to give growth factor agents like TPO-mimetics, L-trombopag, most commonly used, which can have trilineage effects because we know the receptor for L-trombopag, c-MPL, is expressed on hematopoietic stem cells. And that's why it's actually, part of the regimen upfront with patients that don't get transplant, that get cyclosporin, horse ATG, and L-trombopag. And also we know L-trombopag is a single agent for refractory aplastic anemia, can have activity, and you can see trilineage recovery. So very common for us to look for, what are the factors? Are there drugs? Are there infection? Is it graft rejection? And if we don't see any of those things, to put the patient on a course of L-trombopag, hoping that will improve graft function. The last thing that I'll mention is a stem cell boost. Sometimes we'll see patients that their marrow took a big hit from something. Let's say they had CMV reactivation and they were treated with ganciclovir for a prolonged period of time, and they develop very, very bad counts and cytopenias. Sometimes we will bring donors back and we'll G-mobilize them and CD34 select their stem cells and give a stem cell boost, which can be quite effective in enhancing marrow recovery. I've also seen patients get a G-mobilized peripheral blood stem cell boost with Campath for in vivo T cell depletion to prevent GVHD associated with the stem cell boost. So those are all the options in the context of poor engraftment.
And I think this is an important question for maybe centers that they don't have the capability to transplant, especially in the refractory setting. So why should centers without this capability should be making referral even for the second opinions?
Yeah, I think it's when you get a patient that develops a severe opportunistic infection, if they're not in the right place and they can't get something like a life-saving transplant, that they may not have opportunity to get a treatment that would be life-saving. And we have had referrals for patients internationally who when they contacted us, they were dealing with an invasive fungal infection associated with sinus involvement and bleeding, where the patient couldn't travel. They were too sick to come to us, where it would have been a lot better had they contacted us a month or two before, so that if the patient was going to fail immunosuppressive therapy, that they would be in an environment where we could move to a transplant and move to a transplant quickly. And we do have patients here at the NIH that get immunosuppression that we are watching with a transplant backup option planned, where we can go in a couple of weeks if they run into trouble. And I've seen numerous patients that were 2 months into immunosuppression, no response, ANC of 0, and then suddenly they're having problems with recurrent bacteremia, or have a invasive fungal infection where they have to have a debridement in their sinuses, and we'll move very quickly to transplant those patients, because with the transplant we can get neutrophil recovery a couple of weeks after the transplant. So very important they be in the right place when you're managing them in the event that they need to go to transplant quick.
Yeah, I mean, I think this is also another piece that we want to give to our listeners, what we should not be doing when we are dealing with aplastic and transplant.
Yeah, and I wrote these down, and I'm really glad you asked this question, because I see things that shouldn't be done all the time in these referrals. So one of the most common things that I see with aplastic anemia is it took too long to make the diagnosis, and they had originally the incorrect or an incorrect diagnosis made. So a patient that presents like this, that gets a bone marrow, they see some plasma cells, and they go on a workup for multiple myeloma, when the bone marrow is completely empty and it's just some plasma cells. The other thing that throws folks off quite commonly is that they see some dysplasia in a lineage, and they make a diagnosis of myelodysplastic syndrome incorrectly for mild erythroid dysplasia, particularly when patients have PNH clones. Very common to see some erythroid dysplasia. I've even seen patients with PNH getting GCSF that were neutropenic, that made their myeloid cells look immature and blastic, where they made a diagnosis of MDS with evolution to leukemia, and they were basically just looking at a GCSF effect. So the other thing that we see commonly is that some centers will be very proactive with doing the most up-to-date testing, including bone marrow failure panels for using next-gen sequencing, and then they'll see some of these variants of unknown significance show up, that in the report it will describe a mutation, and it will say that this has not been seen before, and this is predicted to not result in bone marrow failure or have a phenotype, but we don't know. And then people get confused and sidelined, and next thing you know, by the time you're hearing about the patient, it was because they were working them up in the context that they had MDS, when all along it was just aplastic anemia. We see patients with aplastic anemia with a PNH clone that were misdiagnosed as having PNH and were started on eculizumab, for months and months, with no response. And PNH and aplastic anemia often go hand in hand, and you shouldn't be thrown off if you pick up a PNH clone by that in the context that the bone marrow is empty. Eculizumab is not going to make the bone marrow recover if there's immune-mediated aplasia. You can treat a patient with immunosuppression and have their counts come back, and they can have a big PNH clone, and then you can give eculizumab, but you have to deal with the bone marrow failure, whether it's a transplant or immunosuppressive therapy. And then ITP, I see that all the time, that a patient is diagnosed with ITP. ITP doesn't cause neutropenia. ITP doesn't cause red cell transfusion anemia. So it's just amazing that how many times that I see patients that come in with pancytopenia that are initially diagnosed with ITP, that are given steroids, and are given IVIG. So I would encourage you all to not make that mistake. The other thing that I see is often delays in treatment because of trying to attribute the bone marrow aplasia to something environmentally, such as a drug or an exposure to a toxin. And we get referrals where so-and-so is working in a gas station and was exposed to gasoline and come in with pancytopenia, and where they sit on them and say, well, let's see how they do without being in that exposed environment. That's a waste of time. Their counts are not going to come back by not working in the gas station. And then also attribution of drugs. In most cases, those kind of attributions are not solid, and stopping the drug in the context of an empty bone marrow rarely is going to improve the situation. Treating aplastic patients with steroids is a recurrent classic mistake. Steroids do not work for aplastic anemia. Immunosuppression with ATG, cyclosporin, L-trombopag works. Steroids don't work. Dr. Neil Young, who has pioneered treatments for aplastic anemia, continuously is baffled by how patients end up getting on steroids, and says that he is looking for the textbook that says treat aplastic anemia with steroids so that he can burn it, or burn those textbooks wherever they are, because they don't work. And when you have a neutropenic patient that you put on steroids, you're adding insult to injury in terms of increasing the risk of them getting an opportunistic fungal infection or bacterial infection. The fourth most common mistake is not putting patients with severe neutropenia on fungal prophylaxis. I see it all the time. I see great centers that are doing great things for patients and are, doing all the testing and then, forget or don't think about putting them on antifungal therapy. And then next thing you know, they run into a fungal infection that ends up, in some cases, unfortunately, preventing them from even going onto a transplant, or could be lethal. And then the fifth thing that I see is that aplastics get platelet transfusions, and nobody checks a post-platelet transfusion count, and they say come back in 3 days. They get a platelet count of 3,000, they transfuse them, they come back in 3 days and their platelet count is 1,000, and they transfuse them and they come back in 3 days and it's 1,000 and they're bleeding. And these patients sometimes come and they're alloimmunized coming right out of the gate. And you really have to check a post-platelet count to make sure they're getting proper bumps to decide when they need to come back to be checked again. And also, if they are HLA alloimmunized, this gives the blood bank a chance to recruit HLA matched donors, so that that person that doesn't bump to sort of the community pool of donors will have a chance to get a good bump. And this is something, again, we see here all the time. Patients refer to us that aren't getting bumped. We find HLA antibodies, we recruit the right donors, and they go from no bump to getting fantastic bumps, to 40, 50,000, where they only need platelets once every 5 to 7 days. So those are the most common mistakes that I see done by hem-oncers for aplastic patients.
Okay, great. So I think we can pause here and see if there's anyone has any questions. But before anyone will ask the question, so what is your approach for post transplant antifungal or any antimicrobial approaches?
Yeah, a lot of times that is driven by the regimens. It'll be incorporated into the regimen. So we have become much more liberal with the use of broad spectrum antifungals. And I'm not sure that that's actually the right thing to do, but the price, a lot of these things have come off patent and the price has come down for a lot of them. So the difference in price between fluconazole, posaconazole is not anywhere as dramatic as it used to be. We will typically, for the first 100 days, cover patients with an antifungal. And during the neutropenic phase, we will use a broad spectrum antifungal, typically posaconazole. In some cases, if there's a problem with posaconazole, we'll switch to voriconazole or isovuconazole. And then once they engraft, uh, and their neutrophil count comes back, and they're not at risk for aspergillus or mucor, but they're still CD4 lymphopenic, and they're at risk for things like cryptococcus or maybe Candida because they're on steroids. Those patients are often switched to fluconazole and then
Mhm.
continue with fluconazole, usually to 100 days. Sometimes we don't switch them when they engraft, and that the reason that we don't switch them sometimes might be in the context that they develop GVHD and they're on steroids and they are at risk for aspergillus or mucor post-transplant, and we want to keep them on something that has broader coverage. So we may
Mhm.
continue them on POSA in that setting. The other thing with switching you have to be careful about is that the interaction on metabolism of calcineurin inhibitors is different with POSA or VORI compared to fluconazole, and is also dose dependent. So you may have somebody that has a perfect cyclosporin level,
Mhm.
and you're 30 days post-transplant, and you say, okay, let's switch from POSA to fluconazole,
Mhm.
switching to a drug that is less broad and it's going to be cheaper, and then suddenly they come back, a week later, and their cyclosporin levels are no longer therapeutic.
Mhm.
And what's the risk with that? Well, the risk is that they could run into graft versus host disease, for instance. And then you have to be titrating the doses, and you have to be bringing them back, every couple of days to see where their levels are. So sometimes it's just easier to leave them on the same agent until you ultimately stop it.
Okay. And we also sometimes hear the PJP prophylaxis not to be used on post-transplant. What's your approach with that?
Yeah. So we typically will give PJP prophylaxis as long as a patient is on any immunosuppressive agent.
Mhm.
And then once they come off, we stop it. The caveat would be that we're looking at immune recovery
Mhm.
in those patients, and sometimes patients have very poor immune recovery. So they'll come off immunosuppression, but they'll have CD4 lymphopenia that will continue. So we normally, if they're off immunosuppression, their CD4 counts over 200, we stop PGP prophylaxis. If it's under 200, we usually continue it until it comes over there, because the risk of PJP with a CD4 count over 200 in someone who's off immunosuppression is very low.
Okay. I think just to respect your time, we have two questions to ask from audience. When interpreting NGS panel, what is your approach for VUS?
My approach is to read the report very carefully, and if there is a description that says that biologically this is an area that could result in interruption of a protein that could be pathologic, that has a very different diagnostic impact to me in a VUS, and as opposed to this would be predicted in silico to not translate into something pathologically, but it still meets the criteria for VUS. That's what I most commonly see, is that
Okay.
this has not been seen before. It would not be predicted to be pathologic, but it's still a VUS. My approach in that context is to note it, but to move forward and to not alter my
Okay.
management approach for the patient.
Got it. And then when it comes to, I mean, I think you went over this, but the marrow failure or the inherited marrow failure workup and urgency for transplant, and you said we don't wait for NGS results to come as long as the telomere and as well as the EEVs are unremarkable, will proceed, right?
That's right, in the context of no family history. So, now if I hear something funny is going on with, we'll ask the typical questions. Does anyone in your family has had, blood counts that have been low in the past? Have they had pulmonary fibrosis? Have they had cirrhosis at a young age? Those kind of things where we're looking for, could there be a telomeropathy, in the family. It's very rare that we would have telomere lengths that would be, that wouldn't be short, where we would hear of a family history that would be suspicious. But if we were to see that, sometimes we'll see borderline short telomeres where we'll say, it doesn't look like it's that short. It's not 2 standard deviations below the norm, but it is short. And then they tell us about, Uncle Joey, who got a liver transplant when he was 30 years old because he was, a big drinker. But the weird thing was that, he swore to God he only drank, 2 beers in 6 months. And there were a lot of people with, that had telomeropathies that were diagnosed with alcohol associated cirrhosis that probably never had that, but nobody, could think of a cause. So they felt like, the patients weren't being honest. So if we don't hear that family history, we have, Fanconi that's negative and telomeres that look good, and we don't see any, anything phenotypically that would look suspicious, dyskeratosis or premature graying, which is, we move along and go to transplant quickly.
Okay, awesome. Thank you again. I think we covered most of the transplant and aplastic components, and I love the 5 mistakes that should not be done. I look forward to hear more about that cord blood to transplant options, and hopefully we'll meet at one of those Cindy's dinner at ASH.
Yeah, great seeing you, and I am definitely hoping to see you at this year's ASH meeting.
Thank you again.
We should be allowed to travel, and I'm excited to hopefully present the data on the expanded cords.
Looking forward. Thank you so much.
Right.
Bye-bye.
Take care. Great seeing you.